Hello, and welcome to the symplr Education Series webcast. Today's webcast is titled The True Cost of Patient Collections, Inside and Out, with speaker Josh Shipman. At the end of this session, we will have time for a formal Q&A, but feel free to ask any questions as they come to mind via the chat box located on the right side of your screen. You will also be able to download the archive of today's webcast and its slides at symplr.com soon, and will receive download information via email. Next slide. The symplr Education Series is sponsored by Cactus from symplr. We are so pleased to have Josh as our speaker this month. Next slide. Josh is a Senior AR Efficiency Specialist with TSI, the nation's leading provider of technology-enabled patient accounts receivable management solutions. He is also an MGMA Executive Partner. For more than 5 years, Josh has helped medical groups improve their internal collection performance to substantially reduce costs. I'd like to turn it over to him now.
Thank you, and thank you all for attending this webinar. And just for clarification, I am an authorized agent for TSI, which is a MGMA executive partner. Ultimately, unless you're running a concierge elective surgery practice in an affluent demographic, chances are many of you have unpaid balances. Now, the net return your practice will realize from these balances will depend greatly on your understanding of your cost and individual patient payer types. During this webcast, we will cover the importance of effective revenue cycle management, factors that negatively affect net collection results, both internally and externally, and finally discover techniques and technologies for which to improve the efficiency and effectiveness of post-service patient follow-up and collections. Now, of course, revenue cycle management is the process of managing financial obligations before, during, and after a patient's visit. This encompasses certainly both management of insurance claims and ultimately the patient responsibility. Our focus today identifies progressive systems designed to increase patient account resolution post-date of service. A well-designed revenue cycle management system will be able to communicate with your EHR and accounting systems. Ultimately, the importance of revenue cycle is to maintain positive cash flow, which is the lifeblood of your practice, and therefore it is important to understand that receivables do not equal cash. Your cash flow is your ability to quickly and effectively turn your receivables into usable cash. And there are obviously certain reasons why this is important. Well, the first being debt management, which is your ability to pay off your current payables. Next is growth management, or the ability to invest in expansion projects. And third, maintaining flexibility, or the ability to respond quickly to emerging challenges. It makes it easier to make critical purchasing decisions rather than postponing them. Now, practices often believe they're doing a fairly good job, and ultimately what they're saying is they don't believe there is room for significant improvement. And in fact, very few practices actually track their numbers or know how those numbers really compare to their peers. Now, just last month, the MGMA partnered with TSI to develop a white paper. The report provided MGMA membership data and benchmarking results of better performing groups when comparing accounts receivable. As you can see, bad debt per physician for better performers is less than half that of others, even though their collection percentage is roughly 99 versus 96% respectively. Now, most offices would certainly consider 96 or 97% pretty good, while others believe they have a high collection percentage but may not be adjusting out credit balances. And so, by the way, if you're not an MGMA member, I'd highly encourage groups to join the MGMA. And should you wish to request a copy of this report in its entirety, certainly feel free to contact me directly through email or via LinkedIn. Now, we all know that accounts are more difficult and costly to recover as they age. So why do we continue doing things exactly the same, hoping for different results? The point is that time is not on our side. Since unpaid balances depreciate at a rate of 15% per month, practices must be able to leverage the newest tools, technologies, and techniques to collect on their balances earlier. Now let's evaluate problems with traditional approaches, beginning with measuring internal cost. Your costs include the total overhead dedicated to internal billing, which keep resources from other, oftentimes more productive tasks. These associated billing costs are identified by the 5 Ps, which include paper, printing, postage, partition utilities, and most importantly, personnel time. MGMA estimates have shown that practices spend as much as $10 when generating a bill internally. Once a practice realizes the actual cost, they begin looking at their billing process very differently, and many to the realization that they're spending more than what some balances are actually worth, while others set payment terms, ultimately costing the business 25 to 30%. Let's say, for example, should you send 3 reminders on a balance of $100, you've lost 25% or more of its original value. Now that we understand your cost, where is your time most productive? Medical staff often wear multiple hats, and they perform various tasks, some more productive than others. In fact, more often than not, when asked how many follow-up calls are made, the response is not as often as we should, or only as time allows. Now, this is a clear indication that most practices are conscious of where their time is least valuable, but nonetheless neglect an important aspect of the revenue cycle. By leveraging automation, staff can focus their time on more productive roles or important roles while increasing the consistency of internal follow-up. Next, staffing ratios and the question to hire or not to hire. Practices may consider hiring replacement or even additional staff to cover billing, and in some circumstances the practice may have experienced an increase in patient volume, but they're simply restricted by physical space to hire additional staff. An administrator once told me that he didn't really think he had a receivables problem, as he had a centralized billing department which handled it. When the number of billing staff or the number of providers, it became very clear the real issue was indeed not receivables, but that of payroll. The ultimate balance is to avoid being either under or overstaffed. Consider checking MGMA benchmarks within your specialty to determine healthy provider-to-staff ratios. Consider automating some of your processes to see if you can arrive at a better ratio, or perhaps repurpose certain staff into more productive roles, such as registration, patient financial counseling, or denial management. Now we turn to external collections. Once internal resources are exhausted, many practices then turn to third parties. Here too, it is important to understand the true cost and be able to look beyond the percentage. Keep in mind that many agencies often have the same issue as your internal staff, and that is time and the depreciation of accounts over time. Most agencies only have the dedicated resources to contact your balances while ignoring the lower ones, and this is known in the industry as skimming. So in scenario 1, place yourself in the role of an agency who is paid 30 to 40% on only what is collected. You receive 5,000 new client balances each and every day. Half of your balances are above $1,000 and the rest are below. In that case, where would you want your staff to focus their time? So of course the logical answer would be the larger balance. The only caveat to that would be balances above 4,000. Because the following day, you and your staff receive a whole new batch of accounts. Now agencies often reply by saying, well, it doesn't cost anything unless we collect, so there's nothing to lose, right? Well, in reality, the true cost of collection is what's not recovered. So in scenario 2, you transfer $100,000 in balance value to an agency over the course of a year. A quarter of those accounts will be actively worked. 11% is the gross amount collected, but after fees, you only net $7,000 or 7% of the total. So the true cost is not the $3,500 to $4,000 cost of contingency. It is the $93,000, or otherwise 93%, that will not show up on your books as positive income. The next agency issue, and to the frustration of your billing staff, many accounts may only require a single third-party contact to motivate payment. I know many of you have turned accounts over to a third-party agency, and immediately the patient then all of a sudden wants to pay the practice. Now, industry sources say as much as 88% of the money that will be collected by a third party will be collected through the mail. And the reason this is important is that all agencies are required to mail out a notice of debtor rights. Now, these are accounts that agencies often depend upon and what is referred to as low-hanging fruit, which just costs you 30 to 40%. So consider investing time in reviewing early out solutions, which we'll discuss in a moment, to identify and resolve these accounts earlier without being charged a percentage. Now, I recently consulted with, a couple months ago, a practice that actually employed two agencies. One charged 35% while the other charged 25%. And after I asked if they divided accounts among agencies equally, the administrator said, well, actually, we ended up turning more accounts over to one agency because we realized better results. Now, any idea which agency recovered a higher net back recovery? Absolutely. It was the one with the higher percentage contingency. So ask yourself if you're interested in a higher net back recovery or ultimately a lower cost. Negotiating a 25% contingency may sound like an accomplishment to save money, but as an agency, which accounts would you prioritize? The balance is making 25 or 40%. If you're throwing money into a black hole by using an agency without results, then why go through the effort? But conversely, it should also be stated that if you're extremely happy with your agency results, then too, you might want to ask why. The chances are they are happier with you, indicating improvements that could be made earlier in the process. To encourage earlier transfers, some agencies offer tiered systems where older accounts incur higher fees. And unfortunately, traditional collection systems often lead to garbage in, garbage out. The fear of losing control or the cost of high percentages often creates a sense of, if we only contact the patient one more time, maybe, just maybe, they will pay. By using this emotional-based method, accounts only transfer once their values have significantly diminished. Now, perhaps the greatest cost, internally or externally, is compliance risk. Here are just a few articles to point to that potential risk, and there are many others that I'm sure you can see on a daily basis. In the last 7 years, the number of lawsuits accusing collectors of violating federal law has increased 5-fold. Here is an orthopedic group that ended up paying $750,000 due to the lack of a business associate agreement. There's a provider that was sued for lack of prior express consent when contacting a patient in violation of the Telephone Consumer Protection Act. So, are you in compliance, or are you simply rolling the dice? You and your agency must comply with the Fair Debt Collection Practices Act, the Telephone Consumer Protection Act, and of course HIPAA, as well as individual state laws. So ask your agency if they're even licensed to collect. Do you have a BAA in place? And do you provide a hold harmless agreement for your clients? Next, we discuss patient responsiveness. Practices must realize what motivates one patient to pay will not work for another, and therefore billing them the same is not cost effective. So it's important to have awareness of progressive solutions to help bridge the gap. 4 patient payers have been identified here, and we'll touch briefly on each with their solutions in greater detail throughout the remainder of this presentation. The first group is described as dependable and require typically only a single statement. The good news is that most patients fall within this group. However, if all of your patients were dependable, there would certainly be no need for follow-up, much less collections. Which brings us to the next group, which we describe as distracted. And they require reminders. We all know that statistically, medical debt has the least priority over all debts. The question is, how do we change this priority while balancing patient relationships? It is estimated that 35 to 45% of patients require reminders. This is where first-party follow-up services can be more effective than continued monthly statements. They generate contacts in your practice's name, but more frequently and at a lower cost than typical internal statements. The third group is appropriately described as disrespectful and require demand letters. Unfortunately, it is this group who often end up lost to intensive collections. Therefore, practices should be aware of early out contacts, which create third-party impact but without costly percentages. And then finally, we have deliberate debtors, which I'm sure most of you are familiar with, traditional agencies which provide professional collection services for a percentage of what is collected. Ultimately, groups should see 40% fewer patients reach intensive collections when progressive solutions are properly implemented. Next, we'll take a 4-step approach to improving your cash flow, starting with a couple internal recommendations. Now, there are several things a practice can improve upon to help increase internal collections. And this begins with setting the right expectations, including a well-written financial policy, which is the backbone of your financial practice. Having a clearly defined financial policy gives staff documentation they can stand behind, but it must be clear and follow national and state statutes. Just because your policy states that patients are responsible for added interest and collection fees does not mean it is allowable by state. Specific language is often key. So you might consider consulting with an attorney to ensure proper language requirements are met for things such as added fees and cell phone authorizations, whether that be first-party or third-party authorizations. Next, the statement. Removing patient billing statements that include aging columns. Statements should only indicate amount due. This reduces the potential for distracted patients to see the balances in a 30-day ledger followed by blank 60 and 90 days, therefore wrongly assuming that they have 60 or more days until their balance is really due. Training staff. Consider role-playing common scenarios with your team, including standardized scripts. Now, this may be intuitive to senior staff, but everyone should be on the same page. For example, we all know you should never say your insurance will or even should cover, as obviously it leads to obvious problems. Instead, consider the following statement. The cost of this procedure or your procedure is, your estimated coverage is, however, the amount your insurance covers may vary depending upon your individual policy. If you have any questions regarding a balance you receive, please contact us immediately. We are here to help. This statement should be backed by the financial policy outlining the role of insurance and the patient's responsibility. Now, on occasion, a patient may be short of paying their balance in full, and you should not ask how much can you pay or when can you pay. Instead, try asking how much are you short. This lets you determine the amount of payment and more effectively conveys that you're trying to help. Statements like, will you be in today or tomorrow allows you to define the time frame. Make sure that your staff are comfortable and that they are assumptive and not afraid to ask for payment. Make sure billing staff are aware of acceptable billing terms and never spend more than a balance is worth. Believe it or not, I've actually had clients who bill patients $5 a month on a $200 balance. Guys, that's over 3 years. Chances are they'll still have an outstanding balance by the time they require additional service. Again, time is the single biggest threat to your cash flow. the longer the payment terms, the more likely default rates will increase. In most scenarios, patients can at least afford $50 or $60. Practices might also consider offering non-interest third-party financing options through various vendors, but make sure the patient can't pay, because one caveat is the cost to the practice can be 10 to 15%. It may also be an alternative if the patient can't make payments more than $60, and your internal resource costs of billing begin to exceed the cost of financing. And in severe cases, it may be necessary to eventually refer the patient to indigent programs or make charity care determinations. Next, we'll discuss alternative solutions and how they apply to the 4 debtor types, with the first being co-sourced first-party follow-up. Internally, practices see the highest return on their time when billing dependable patients. However, again, returns diminish greatly after the first or second contact. At this point, first-party follow-up solutions can be an effective alternative. They send multiple contacts more frequently, more consistently, and at a lower cost than internal resources. Contacts appear to be generated directly from your practice and often include a remittance voucher and return envelope addressed back to your practice. This helps cap internal resource expenditures and frees up staff for other business tasks. By creating urgency through frequency, they significantly improve the cash flow on distracted patient-payer groups. Some options even alternate reminder statements with phone calls, which are connected directly with the practice for direct payment. If your current solution generates statements that look alike, you might consider vendors who offer variations to increase the overall impact. Next, we discuss early out solutions. Once patients reach 90 to 120 days past due, they're then categorized as disrespectful, but not all are deliberate. And at this point is when early out solutions are most effective. Typically, this group avoids contact because of a misunderstanding with their coverage, not the practice. 90% of the time, if you only had an opportunity to address this directly, they would be more understanding and ultimately pay. And unfortunately, it is this group who often find themselves reported to intensive collections where all of a sudden they now want to work things out directly. But by this point, it is out of your hands and you lose 30 to 40%. Alternatively, flat fee early out services provide third-party impact, yet cost 75% less on average as compared to traditional percentage agencies. They avoid skimming of balances. They're effective on low-hanging fruit without costly percentages. They significantly reduce the number of patients requiring intensive collection efforts. They provide more flexibility and control. And ultimately, it is like the practice is leasing the agency's license to collect. And finally, professional collections. When practices properly use first-party and early-out solutions, 30 to 40% fewer patients typically will reach this point. However, those who do reach this point have clearly defined themselves as the deliberate and require a professional approach. In some cases, you may not have a valid address, making it quite impossible for your staff to work. Professional collections provide national reach, skip tracing ability, they're skilled in collections law, and provide additional consequence for non-payment with no cost unless they collect. Now let's review all 4 patient-payer types with their recommended solutions to demonstrate how they comprehensively improve the efficiency and effectiveness of your internal revenue cycle. Step 1, internal statements. By focusing on just 1 or 2 statements, practices maximize return on internal effort while allowing your staff more time for other areas of productivity. Step 2, first-party reminders. These multiple reminders create urgency through frequency, where practices experience a 50 to 75% recovery on past due balances at virtually no net increase in cost based on internal resource savings. And all statements appear to be generated directly from your practice. Step 3, early out demands. This is a third-party impact that you control, where practices resolve an additional 30 to 40% of delinquent balances at a fraction of the cost of traditional resources. Again, avoiding the high costs associated with low-hanging fruit and skimming. And then finally, step 4, professional collections. Only for accounts proven to be difficult or those with invalid addresses for additional recovery income. As you can see, by using a progressive approach within each stage, fewer patients will funnel to the next, resulting in reduced costs and improved efficiency. Now that you're familiar with these alternatives, you might also consider technology-compatible solutions to further enhance your patient selection and review process. Most practice software have partnerships in place or compatible with add-on value-added resellers, which can significantly improve the efficiency of various AR functions, and in some cases, all you have to do is activate or turn the function on. Technology-enabled solutions automatically identify overdue charges for review based on default criteria set by you and your staff. This might include age of patient responsibility, number of statements generated internally, and or minimum balance due. It then quickly generates file groups which can be securely transferred into desired follow-up or early out solutions of your choice. This reduces manual data entry, emailing, or faxing of sensitive patient information with no need to print aging reports for review line by line with highlighter. And in some instances, they even include or exclude accounts on payment plans with the option to not exclude if the payment is delinquent by X number of days. Interfacing options include those for Centricity, Allscripts, ECW, Athena Health, just to name a few, and I'm sure that most of you have utilized one of these solutions or have a compatible solution available for your EMR. So finally, before you choose a collections partner, there are 5 things a practice should consider. With over 4,000 collection agencies, only a few are able to pass the test. Number 1, personal consultants. Do you dial a 1-800 number, or do you have direct access to an individual personal consultant? Do they work with you and your team and coach them on best practices? Number 2, is your agency investing in your success? Do they offer early out services to reduce costly low-hanging fruit sent to intensive collections? Do they provide real-time reporting so you instantly know what your results are? Amazingly, when asked, most practices have no idea what their agency's actual recovery rate is. And as pointed out in the previous slide, ask your agency if they offer solutions for your specific EMR or practice management software. These solutions help save staff time and manage accounts by securely transferring only the accounts they've selected without time-consuming data entry or reviewing pages of aging accounts. If you're using a collection agency that requires you to fax paperwork or provide copies of sensitive patient account information, it's time to consider your options. Which brings us to the next point, which is legal compliance. Is your agency compliant, or do they place your practice at risk? Ask your agency how long they've been in business, where they are licensed, and what measures they take to be TCPA and PHI compliant. And then finally, are they nationally vetted? Few agencies have undergone the vetting process to become approved by groups like the American Medical Association, the Medical Group Management Association, or peer-reviewed by the Healthcare Finance Management Association. These organizations have access to industry-specific benchmarks, so you can be assured that their stamp of approval has credibility for top performance and satisfaction. If your agency meets all 5 of these criteria, then you have a partner you can trust. Thank you, and now I turn it back over to symplr.
Thank you so much, sir. And now we'd like to take a quick break to talk about symplr and Cactus as it relates to this. Next slide, please, sir. If you could hit play, we have a short video for y'all.
Thank you for looking at symplr for your payer enrollment. Why choose symplr? At symplr, we have a dedicated team to completing payer enrollment. This expert team manages the full life cycle of payer enrollment, enabling completion at the time, from large multi-hospital systems to surgical centers. Symplr's payer enrollment services are scalable within your facility. Our enrollment services save you money by streamlining the entire enrollment process. If you are interested in exploring payer enrollment services, please reach out to us at sales@symplr.com or give us a call today at 800-373-9725.
Thank you so much. I believe you can click to the next slide. Yep, for more information, please email us at sales@symplr.com. And now it's time to have a Q&A with Josh. I haven't had any questions roll in quite yet, so it seems that people are still digesting what we went over. I would like to remind everyone that we will be sending out information on how to download today's slides and the webcast archive via an email. Make sure you add communications@symplr.com to your address book to ensure that you have the ability to receive our emails. Mr. Josh, do you have anything you'd like to say kind of that you didn't get to everyone during the presentation, or anything you'd like to say in closing?
No, again, I would just like to thank all the attendees for joining today. Hopefully, it brought about just thinking outside of the box and perhaps bring about some options or alternatives that you may not have been familiar with or have used in the past. Certainly, if you have any questions that come up, or again, if you would like a copy of the MGMA white paper, feel free to contact me directly, and I'd be happy to forward that to you.
All right. Well, thank you so much, sir. I'd like to thank everyone for joining us this month. We hope to see y'all next month. We do have, if you'll advance the slides, sir, we do already have this webcast planned. Oh, maybe you don't have the last slide. There we go. It is How to Avoid the Payer Enrollment Black Hole. It's happening on July 27th with guest speaker Kathy Matzeka. You can register online, and you'll also be able to register from the slide download once I get those online. We hope that everyone has a great day, and we hope to see you next time. Goodbye.